It could be interesting for you, Nancy, to see what happened in 1972. You said something about 1972. Yeah, you visited Sweden in 1972. Fiskebäckskil. Yeah. And you were the center of attention.
Well, I was short and dark.
But other things happened at 72. Most of the students here have seen the residents. Yeah. But something else happened in 72. I don't think you've seen that picture before. And we're very happy to have you here because you have been one of the authors. You and Valerie, I think, have done this in... Det dog den här, så jag får prata utan micken. Is it? Okay, it's still working. Okay. And I think the 1st of September there was a 3rd edition coming out.
October.
October.
Otherwise I'd have brought that one.
Okay. If you need to buy one book, I recommend this one. And I looked inside the book, I looked at it, and I found a picture. And it looks very much like you. Maybe back in 72. I don't know.
Yeah, actually that is a picture from Sweden. That's a picture here from...
Oh, really?
Chile. Yep.
Wow. Okay.
It's the head tilt that you should be looking at. And the overaction of the left inferior oblique when I was a baby. Genital form.
And I'm going backwards.
Tilting, I know I'm tilting.
And Nancy, you're working in Atlanta at the Emory University School of Medicine, and you have all kinds of positions. I can't, say them all. There's so many. They don't even fit on this slide. And I think you have over 450 publications. At least it says so on your Emory website. Scientific articles, book chapters, a lot of things. And it says also that your special interests are the optic nerve and mitochondrial diseases. So it's a perfect topic for you to speak about optic neuropathies, I think, then. So we're really happy to have you here. The floor is yours.
So I'm not sure I really want that contraption on my head, but I have to ask in the back. Am I loud enough?
No.
Huh?
No.
So no? Okay. The contraption is... I have to make it smaller. Randy's head is much bigger than mine. Sorry, Randy. So it's a real pleasure to be here and to wear this thing. I'll get used to it.
Oh, you're here, Randy.
Yeah.
You saw the picture?
Did you see the picture of you in high school? Oh, God. I thought I showed a picture of me as 16, and at 6 months, you at 18 is quite something. Well, Randy and I know each other for a very, very long time, and more recently for your mentor here. And I'm really delighted to be here, and once I feel comfortable, I'll be able to speak. My ears sticking out. Okay, it's okay. All right. So, good, we're good, and you can hear me. So we're going to have some fun. I was looking at your schedule, and apparently you've had all this before, but in Swedish. So now you have it in English, right? And that's the only difference. So instead, we're going to do it via cases, and you can see where you are. These are my disclosures, by the way, nothing that's relevant to today's talks. And I'm going to start with a case, and we're not going to answer this case. I'm going to start with a case because if you've got it already, this particular case, you probably can just go to sleep for the next 2.5 hours. But we're going to start with a case that's going to set the stage, and then we're going to move on with a case before each category of what we're dealing with. So this case is of a 39-year-old man who has vision loss in his right eye. His past medical history is notable for hypertension and cigarette use. He's on atenolol. His family history is unremarkable. And 5 weeks before you see him, he has progressive, painless vision loss in the right eye over 4 to 5 days. He's never had any previous vision loss. He's never had any neurologic symptoms. And when he doesn't improve after 5 weeks, he comes to see you. His vision is 2200 in the right eye. The left eye is normal in all respects. He can only see the control Ishihara color plate with the right eye. Everything on your slit lamp exam and external exam is normal. And when you go to check his pupils, he's got a right relative afferent pupillary defect. Here are his visual fields with this central defect more prominent superiorly in his right eye, normal left eye, and here after 5 weeks from the onset of his vision loss, his right optic nerve is on your left, his left optic nerve head is on your right, and I'm not going to talk about what you see there, but you see something. I hope you see a couple things. And so, if you know the answer, write it down. Write it down. Put your nickel down. You do know that he has a right optic neuropathy, even if you hadn't seen the title of the talk, right? Everybody, we've localized this to the right optic nerve. But what happened to this man? What kind of optic neuropathy does he have? And by the end of today, we'll check everybody and you can check what you wrote on your paper and see if you've changed your mind. Okay? All right. So we're going to talk about the optic nerve and optic neuropathies. So you absolutely positively know that you have an optic neuropathy if you have decreased visual acuity, an abnormal visual field, a relative afferent pupillary defect. You can see clearly through the media telling you it's not a median problem, not cornea, not lens, not vitreous, and you have a swollen or a pale optic nerve. You absolutely positively know you have an optic neuropathy in that situation, correct? Okay. And why do you know that? You know that because the optic nerve, even though it's a piece of brain, it's as stupid as every other piece of brain. The only thing a piece of brain can do when it's not happy is to swell acutely, right? And then the only thing it can do is die. And the way you see that in the optic nerve is that if the location of the problem is behind where you can see it, in the retrobulbar portion of the optic nerve, then acutely, when you see that patient, they're going to have a completely normal looking optic nerve. So one way you can see an optic neuropathy is basically you see a normal front of the nerve, right? The patient sees nothing and you see nothing. It's a retrobulbar optic neuropathy. The second way an optic nerve can manifest, at least the piece that you can look at, if it's an optic neuropathy, acutely or chronically ongoing, is to swell. And then the third way the optic nerve can demonstrate that it has an optic neuropathy is that it becomes pale over time. And as you heard from Randy earlier, we're talking at least 6 weeks before you really can appreciate pallor on your fundoscopic exam. 3 to 4 weeks on ganglion cell OCT, 4 to 6 weeks on the RNFL, right? But if you're just looking on examination, if you see paleness of the nerve, you know it's been there, the insult, at least 6 weeks. And these are the only ways that an optic nerve can express itself. So, so it kind of explains, doesn't it, why you have sometimes trouble deciding what's causing an optic neuropathy. Because if there's such a limited repertoire of how the nerve can express itself, look at all the pathophysiologies that can affect the optic nerve. Frankly, if you're a medical student, you learn these pathophysiologies as anything that can affect any piece of tissue, right? Not just the optic nerve. And so the optic nerve can be affected by anything that can affect tissue in a pathophysiologic manner. You can have inflammation, and inflammation can be infectious or non-infectious. I like running this whenever I have a diagnostic dilemma because otherwise I'll forget something, right? You could have vascular, and vascular can be arterial or venous, or it can be arteritic or non-arteritic. You could have compressive infiltrative, and compression or infiltration, compression can be neoplastic, like a tumor, but it could be non-neoplastic, like the case that Randy showed you where an aneurysm was pressing on the nerve, or a big thyroid eye muscle pressing on the nerve, right? That's still a compressive mechanism. You can have toxic, nutritional, metabolic things that can affect the optic nerves. You can have inherited or degenerative things that can affect the optic nerve. And then you've got a group of things I like to call the mechanical way a piece of tissue can be affected. The most obvious mechanism for a mechanical mechanism is trauma. You hit something, you hit a piece of tissue, right? So you could have a traumatic optic neuropathy. But think about, in a way, there are other mechanical ways that we can affect the optic nerve based on the anatomy of how it originates, it connects into an eyeball that has a certain pressure. And it's surrounded by fluid, cerebrospinal fluid, which can also exert a pressure. So you could have mechanical ways of getting an optic neuropathy by either having too high an intraocular pressure or a high intracranial pressure transmitted along the nerve to squeeze the front of the nerve. Then you get papilledema, right? So these are all the different mechanisms, and I probably even could add on to that for ophthalmologists, not for neurologists, it's too confusing, but you could have low intraocular pressure, right? You can get, hypotony could give you an optic neuropathy with disc edema too. So these are all the mechanisms. So let's do them all, but you have to figure out which one each time. So let's start with a case. A 19-year-old woman has vision loss. Her past medical history is completely unremarkable except for obesity. She's on no medications, she doesn't use substances, and her family history is unremarkable. For the past 2 weeks before you see her, she's had severe headaches that are new for her and rapidly progressive vision loss in both eyes as well as double vision. On examination, she's 2100 right eye, 20/30 left eye, decreased colors in both eyes, right more than left. She has a right relative afferent-pupillary defect. Here's her ocular motility, and you can see she's got an abduction deficit on the right, accounting for her double vision. And here are her discs. Yowza! That's pretty bad swelling of the optic nerve heads, right? So I've given you all of her exam except possibly the most important thing. What am I missing? What do you want to know? What do you want to see from her exam?
Intracranial pressure.
Yeah, you want to see that. Okay? You don't need an OCT to see that. Okay? With all due respect to Randy, I don't think we need an OCT in this case. And this is florid disc edema. And look at these visual fields, but she's 20/30 in one eye, 2100 in the other eye. It's pretty good visual acuity. Horrible visual fields. So what's her cause of optic neuropathy? Right, but the mechanism is raised intracranial pressure. Okay, so let's talk about what you want to do right now. So what's the first thing you want to do? Yeah, you want to get I would suggest there's even something before that. No, a blood pressure.
Okay.
You may always be fooled by malignant hypertension. It's not in this case, but you know, I don't know about here in Sweden, but in the United States, it's very hard to find a blood pressure cuff in the eye clinic. You really still need to do blood pressure. Okay, so we heard imaging. If you got the chance, you really want, as someone said, an MRI. You want with gadolinium to look at the coverings of the brain, also to look for any subtle, smaller tumors, and you want an MRV to look for venous sinus thrombosis, right? Very, very important. Okay, next, what's next step?
LP.
LP.
There sure was. That's a very good point. When you say normal, it doesn't necessarily mean that there aren't findings that show high pressure. Absolutely. Okay, so LP, good. Opening pressure, 63 centimeters of water, normal CSF contents. So by definition, and believe I'm not trying to fool anybody here, by definition she has idiopathic intracranial hypertension, what used to be called pseudotumor cerebri, and what specifically this case tells you should never ever be called again benign intracranial hypertension, right? This is not benign.
Yeah.
And all the rules that you read about in IIH even most of the time really don't apply to this woman, because the ER was ready to send her out on Diamox, 500 milligrams, acetazolamide, 500 milligrams twice a day, and see someone back in 3 months. That's not the way to do this, is it? Right? Okay. So she, and then there's some important things to ask for, right? She doesn't have any precipitating factor. She has no anemia, she has no sleep apnea, and she was not on tetracycline or any of its derivatives for acne or vitamin A preparations. So she has, and the reason you don't send her from the ED home, is she has a very fortunately rare condition of IIH, but this is the fulminant form of IIH, meaning the symptoms and everything came on within 2 weeks, and she has horrific visual function, horrible visual function. So they put her on the 500 twice a day, and she had this dramatic improvement between the lumbar puncture and that's where you get in trouble, because she felt so well, you could just discharge her, and that's what they wanted to do. But we consulted neurosurgery. Why do we consult neurosurgery? Because 12 hours later, she has recurrence of her headaches and her double vision. She's now down to 2400. Remember what Randy said, to have central visual acuity involvement from papilledema is extremely uncommon. And when you have it, and on top of that a relative afferent pupillary defect, that means that not only do you probably have fluid in the macula, but you're killing off nerve fibers already. The papilledema is just choking those nerve fibers and they're dropping out. So we put in a lumbar drain. It's like a continuous lumbar puncture until neurosurgery could shunt her. Yes?
I mean, 1 gram damage, it's not
And that's not very much either. But on the other hand, I don't think even giving her 4 grams would have made any difference to what we had to do to this patient.
What's the level where you think would have?
Interesting question. So the question was, when do I feel comfortable enough with just 500? I say never with an onset of symptoms like this, and never if there's significant or substantial visual field loss. And we'll talk about that. All right. So here she is 1 week later. So this tells you that probably a lot of that central visual acuity issue was indeed fluid tracking from the papilledema. She's regained her color vision. She's 20/50 and 20/40. The papilledema is starting to go away. This is just 1 week. But at least she's got something on her gold on visual fields. But this would make her illegal to drive in any state in the United States. Her visual function in her life has been changed. 3 months later, that's the best we could get her back to. And you see the significant optic atrophy. Sure.
What's that?
That's fluid tracking. And you notice it's not what you normally call a macular star, where you have it all the way around when you're talking about a neuroretinitis. This is fluid literally tracking from where you see the high water mark where her disc edema used to be. And so this is where she died. So not hard to pick which category this one relates to, right? This is the category of optic neuropathy of elevated intracranial pressure. And this, we are so concerned about this category that historically we have reserved a specific term to refer to the disc swelling that it causes. We reserve the term papilledema for disc edema due to raised intracranial pressure. Yes?
Does the patient's age can change the outcome? the prognosis.
You know, I don't think that's the case. Randy, have you ever seen the age of onset of IIH change their outcome?
No,
I think
only,
it's the degree of papilledema is much more a feature.
I mean, if they're older, then you look for secondary causes, not idiopathic, but not that.
So, papilledema, discedema from raised intracranial pressure of any cause. It can happen at any age. It's painless unless the underlying cause is causing some pain. And here is the most important thing. It spares central visual acuity until late. Why is this optic neuropathy different from all other optic neuropathies? Well, there's one other that does the same thing. What optic neuropathy spares visual acuity until late and affects periphery first? Glaucoma. The other mechanical optic neuropathy. Very strange, isn't it? Why is that? I don't know. Okay, but remember. So, what are the causes of raised intracranial pressure and papilledema? Obviously, the gumba in the head, right? The mass lesion in the head. Hydrocephalus. I like to think of it as plumbing, right? You've got this fixed skull, can only take a certain amount of stuff in it, so that's where the mass lesion causes it. And then you make your CSF in your choroid plexus, it flows in the ventricles, it goes down the third ventricle into the fourth ventricle, out the foramina of Magendie and Luschka, whatever you want to call them. And then it bathes the brain and spinal cord, and then it gets passively resorbed from a high pressure state in the subarachnoid space across the meninges into the lower pressure area of the venous sinuses, right? And you make your entire CSF in an hour and a half. So you constantly are making and you're constantly resorbing. So if you think about it in terms of plumbing, you can get high pressure in the head if you squeeze that area where it's going to drain, you block the drainage, you get hydrocephalus, right, when you're still internally. If the fluid's made and it can flow through all the ventricles, no problem, and gets out, then any process that involves the meninges, an infectious process like a meningitis, and non-infectious inflammatory process like Crohn's or sarcoid, a neoplastic process like carcinomatous meningitis. Anything that gums up the arachnoid villi, affects the meninges, the CSF pressure is going to have to build up in order to push the fluid across into the venous sinuses. And finally, if you have any kind of something that increases venous pressure, you similarly will have to build up the CSF pressure to get into the venous system. And that buildup could be anything that raises venous pressure. The thing that we're most concerned about are things like venous sinus thrombosis. But for example, if you have a dural fistula in which an artery goes into the venous sinus so that you've got basically arterial pressure in the venous sinus, then that also will cause high venous pressure, and the fluid will have to build up pressure-wise in the CSF to get across. So these are all the causes. So everybody knows what you got to do, right? You see someone who has bilateral disc edema, especially if it spares visual acuity, and especially if they also have headaches, they need brain imaging. If the first thing you can get is a CT, I guess you can get it, but if you can get your MRI right away, don't waste your time, don't waste the radiation, and don't waste the money. Go for your MRI, and you want it with or without contrast, and you want an MRV in the setting. This should give you your answer regarding hydrocephalus, a mass, and usually with the MRV, and even on the regular MRI, you can see clots for venous thrombosis. If it's normal, then you move to the lumbar puncture. If it's an abnormal CSF, you get your diagnosis of meningitis, one form or another, or a spinal cord tumor with high protein. And if the CSF has a normal opening pressure and normal CSF, you scratch your head again and you say, you know what? Maybe it was pseudo-disc edema. Maybe it was optic nerve head drusen. Maybe I didn't notice that it was just funny looking discs. Or recheck the blood pressure, exactly. And or check it at all if they have it the first time around. And if the pressure is greater than or equal to 25 centimeters of water and there's normal CSF, then and only then can you make the diagnosis of idiopathic intracranial hypertension. However, if you have an atypical patient, as Randy points out, they're kind of old for this diagnosis. They're kind of male for this diagnosis. They're kind of skinny for this diagnosis. Always reconsider venous sinus thrombosis and any other underlying reason why they might have it. Okay, so let's talk about IIH. It's isolated intracranial hypertension. It typically causes headaches and papilledema. About a third of patients or a quarter of patients will have double vision from unilateral or bilateral sixth nerve palsy. And a very high percentage, actually, if you ask, will have pulse synchronous tinnitus in their ears. They don't tend to volunteer that. You usually have to extract it, but it's a very, very common symptom in these patients, probably related to pressure in the venous sinuses, but it's never quite clear why that happens. Sometimes it's even loud enough for their bedmate to hear the whooshing. You need that MRI to rule out other intracranial processes of venous thrombosis, and you need the LP to not only confirm the high pressure and to prove that the CSF is normal and it's not some high protein process or meningeal process, but also to start therapy. It's one of the easiest ways to start treatment. Right? Okay. And it is not just a diagnosis of exclusion, and that's why I like the question here about the normal MRI. We now have updated diagnostic criteria. It still is isolated increased intracranial pressure with headaches and these other symptoms, but you really are at your peril to make this diagnosis without papilledema, because there are a lot of obese women out there who have chronic headaches. And if you don't see papilledema, then you really should be seeing the normal MRI findings that are fairly common, almost universal, in patients with raised intracranial pressure, including an empty sella, flattening of the globes, and sometimes even you see the papilledema, and venous sinus stenosis, not thrombosis, stenosis. And this is, depending on how you measure it, what you call stenosis, that's found in nearly 100% of patients who have elevated intracranial pressure. And it has raised the question of, are these stenoses primary? Meaning, because of these stenoses, is that why you have increased venous pressure and therefore increased CSF pressure? Or are they secondary, meaning because you have raised intracranial pressure, there is pressure laterally on these soft-walled veins that makes them collapse? Some argue it doesn't matter, because maybe it's both, and then it's a vicious cycle because one causes the other. But you will see them, depending on how hard you look for them and how you look for them, in nearly every patient with IIH. The CSF has to be normal, and the opening pressure in adults has to be 25 centimeters of water or greater, and in kids, 28 centimeters of water or greater. IIH in the 21st century. It is everywhere there are obese people. And as obesity grows, so does IIH. This is just 2017 numbers. I'm happy to report for you guys that Sweden isn't there, but Norway is. I find very interesting. And of course, at the top, always at the top of everything, is the United States of America, with, in 2017, 34% obesity. My goodness. Well, since you get our Coca-Cola and our McDonald's, you're going to get our obesity sooner or later. And it's a real big problem. As you can see, the dark blue areas, really big problem in a lot of countries. And therefore, IIH is also growing. So, if you look at these epidemiologic studies, you'll see that it is on a slope that is almost exponential. We used to think, this is how I always remembered who would get IIH, this Rubens painting of the three goddesses, and they were female, obese, in their childbearing age. But the reality is these look skinny to me compared to my usual patient. These are the typical IIH patients in the United States. The way you manage these patients, you need to figure out the severity of their symptoms and the severity of their vision loss. Those are the two prongs of your management. You want them to be comfortable and you want to preserve their vision. The comfort is really not about damage. If someone's willing to live with their headaches, their double vision, their pulsing noises, they're not damaging themselves. The visual function is what is damaging and potentially irreversible. And so you have to not only deal with their symptoms, but you absolutely, like a hawk, have to watch their visual function. And the way you do it is you look for these visual field defects, which are the signal for optic atrophy setting in on your patient. And you do not do confrontation visual fields and follow these patients. And it may seem self-evident to you because you own the automated perimeter in your office, but it's not self-evident to neurologists. And I've seen people go blind because they've been followed by confrontation visual fields. These people need quantitative automated perimetry to know what's happening. And initially, early, the main signs will be blind spot enlargement. That I don't treat for. That doesn't scare me. What that is that's swollen nerve lifting the circumferential peripapillary retina more toward the lens. So if you put a plus lens in, you can actually make these blind spots come back to normal size. Okay, so that doesn't bother me. That's not damage. Or there's fluid there, which I know will go away, right? That's not damage. What bothers me on these fields is this. That's more concerning to me than that or that. Because that's the sign of the beginning of the kind of peripheral arcuate field loss that we get. Just like if you had a glaucoma patient who just showed up with that and before had normal, you'd begin to worry a little that your management wasn't working, right? Okay. Then we move on to this. Right? These arcuate defects, an awful lot like glaucoma. Chronic atrophic papilledema, an awful lot like glaucoma. They can get like our patient, who's still seeing 20/30 in one eye like this, and then they can get like this. Just devastating. And then they have secondary optic atrophy. Look how far the high water mark was on this patient. That shows you where the disc edema went out to before. And just because, and this is where Randy and I think, disagree a little bit. I never use my OCT to follow papilledema because to me it's falsely reassuring. Think about it. If it gets lower, you have this high, thickened, it gets lower on your RNFL. Well, that could mean that the papilledema is better, right? It also could mean that you've got optic atrophy and axons are dying, right? Dead axons can't swell. And so you could be happily following your patient with an OCT where it's getting less thick and less thick and less thick and they're getting more blind. So I really believe more in functional measurements like visual fields. There's also something that our group has looked at very closely with thousands of IIH patients, and that is there a way to predict when someone walks in your office with IIH, and this is part of your question before, who I can just put on 500 milligrams of Diamox twice a day and come back in a month or 3 months, and who I need to admit into the hospital, or who I need to give 4 grams, or who I need to operate on next week, etc. And we found that there are indeed several patient characteristics that will portend a poor visual prognosis, and you need to watch these patients much more closely. So in America, it's black race, and this was completely not related to access to care or socioeconomic status. And when you think about it, in the United States, black patients actually have worse glaucoma. And it also is not necessarily associated with demographic factors like access to care. So there's something about the African American optic nerve that makes it more susceptible to poor visual prognosis in this disorder. Male gender. Remember, males don't get IIH as often, 9 to 1, 1 to 9, but when they get it, they tend not to have headache as much, and therefore they tend to be diagnosed later in the course, and they usually have worse visual prognosis. So you need to follow them a little bit more carefully and treat more aggressively. We know that obesity is a risk factor for IIH, but it also is a prognostic sign. If you have severe obesity, a BMI over 40, you have much worse visual prognosis. So there is a relationship. It probably relates to the level of the CSF pressure. And then if you have anemia, sleep apnea syndrome, systemic hypertension, you are higher risk for poor visual prognosis. If you present like our patient, like within two weeks of onset, fulminant type course, you will do worse. And if you present badly, you will do worse. So these are the things to watch for. Now, how do you treat IIH? I like this picture from Hieronymus Bosch, because in some patients, like me with the book on my head, that's me, in some patients, you don't have to do anything. The person who is discovered at their optometric visit to have bilateral disc edema, they have normal visual fields, they haven't had a headache in their life, I can watch those people. I don't have to put them on anything, as long as I know they will be compliant and will try to lose weight. And I watch them. I don't treat them. You can treat them with potions, like acetazolamide, or you can do surgery. So let's talk about the treatment. Treatment begins with the diagnostic lumbar puncture. You make a hole. So you say, well, but you make your CSF back in an hour and a half. Certainly if you take only 10 cc's off or whatever, you're going to make that back like that. Well, it's because you made a hole. And the hole continues to drain. And sometimes it drains for even up to 2 weeks. Additionally, when you change, this is for the people who are into physics and hydraulics, when you change the pressure, it's like having a rubber dome. You drop it below a certain level, it will take way longer to get it back up. So the lumbar puncture really is helpful therapeutically in addition to diagnostically. Acetazolamide, according to the the IIHTT, the idiopathic intracranial hypertension treatment trial, at 4 grams a day, up to 4 grams a day, really does help. 4 grams a day of Diamox, those are a lot of side effects. But, you know, I start people on 500 twice a day or 3 times a day, depending on the clinical situation. I rarely get over 2 grams a day. But the trials show that you can get up to 4 grams a day. Weight loss, absolutely essential. Treat any risk factors that are treatable. You can't treat the fact that someone's a male, but you can certainly treat their anemia. And you treat their headaches, because you know what? The acetazolamide on the IIHTT, it made their papilledema go away, but not their headaches. And either their headaches will do something else, or what I think is more likely is in the susceptible person, once you perturb the dura, like with high pressure or a brain tumor or whatever, you precipitate chronic headaches in the susceptible person. And that's why you need help with a neurologist. These patients often just need headache management, even when their papilledema has gone away. And then predict the prognosis by following their visual fields and their fundoscopic appearance. And then you have surgical options. So let's talk about weight loss first, because I don't know, how many of you have told a 300-pound woman that she's got to lose weight? Come on. Don't you think she's always wanted to lose weight and has tried to lose weight? And frankly, to be the svelte person she wants to be, she probably needs to lose 150 pounds. It's hard. So what you have to point out is that to reverse this disease with weight loss, you have to lose only between 6 and 10%, as little as 6% of your body weight. So that 300-pound person maybe needs to lose only 25 pounds. That's a lot easier to get your arms around than just telling them to lose weight. So this is a very important statistic. But you know what? It really works. And what else works is bariatric surgery. And let's not forget that. The problem is that bariatric surgery has its own slew of side effects and problems, some of which are actually neuro-ophthalmic, and we may get to that later. So, as I mentioned, the IIHTT looked at acetazolamide versus placebo. Do remember that every one of these patients also had weight loss training, nutritional counseling, and so it's not maybe the patients you see, but indeed the endpoint being the visual field, basically it showed that acetazolamide worked and the papilledema went away, but headaches were not affected. So here's what I kind of do. It all depends on the visual field. If the visual field does not improve or worsens, that's probably when I head to the surgical side of things. And my follow-up, I wish I had a recipe to give you. I don't have a recipe. It's really depending on how compliant the patient is, how bad their vision is, how bad their symptoms are, how closely I have to watch. If there is worsening of vision despite medical treatment, and there are symptoms that are really bothering the patient, I still think that a CSF shunting procedure is the way to go. Typically now it's a VP shunt that's done, not a LP shunt, because they have stereotactic ways now of getting into the ventricles, and it's usually it doesn't give as much trouble as the LP shunt. I reserve optic nerve sheath fenestration for when it's really a rapidly progressive vision problem, a severe vision problem, and they don't have much in the way of symptoms. Because the optic nerve sheath probably is its own tiny little shunt, but it's not enough to decompress the whole head. How many of you have been exposed to venous stenting for this disorder? Has that made it to Sweden? No. So remember, and we'll get into that, remember those stenoses? So people feel, well, if you open the stenoses, maybe you'll lower the venous pressure and you'll break the cycle. So we'll get to that. So don't forget, emergently, you can put a lumbar drain in while you're trying to figure out who's going to help you. And I would argue those who are so into potentially doing optic nerve sheath fenestration, because these patients can then be yours, so that basically you could do your VP shunt here or your teeny little shunt there, but at least you're then protecting the fluid will come out before it gets to that sensitive part of the head of the optic nerve to cause papilledema. But then these are your patients, with all the attendant things that come with general anesthesia with these kind of obese patients. So the neurosurgeons don't really want them either, but it's a lot easier to go into the head than it is to go into the belly, and that's kind of why I think they're shifting their way they do it. So this shows you CSF shunting goes from having an abduction deficit to it clearing, and that's one of the advantages. You're not going to clear someone's diplopia with an optic nerve sheath fenestration, right? And it's pretty good for the visual fields as well. There is now the surgical IIHT treatment trial called SIGHT going on in, yes? Oh, I'm going to finish. That'll be perfect stuff. Good. The surgical treatment trial site in which they are doing VP shunting versus optic nerve sheath fenestration in IIH patients. It's ongoing right now. Unfortunately, there isn't a venous stenting arm of it. And here's what I was talking about venous stenting. They put a stent in here, and even if you think it's a primary stenosis, then giving outflow obstruction, venous hypertension Well, that's going to decrease CSF absorption, which is going to make the CSF pressure go up, which is then going to collapse and push on these lateral sinuses and make them go down. So it probably does break the cycle, but right now, don't treat the MRI. Just because there's venous sinus stenosis doesn't mean you have to put in a stent. Everybody who has high pressure has these stenoses, so it's not necessarily the reason that you would treat someone is that they have a stenosis. And as soon as you get someone who owns a hammer, everything's going to look like a nail, right? So as soon as you get someone who's doing venous sinus stenting for IIH, they'll look at every MRV and say, ooh, that's something I could stent. So you've got to be the gatekeepers to know whether it's necessary, especially if the visual function is normal. So in 2019, I think it's very controversial. You put a stent in place, it can cause venous sinus thrombosis locally. We've had one patient die that I've seen, and all you need is one like that, and that's it for us. But we'll see in the future. Who knows how long these stents can stay in these young patients, right? It's an awful long lifespan in front of these patients to have a stent in their head. And that is the end of that category. And so when we resume after the break, we'll do our next case. I think so. So there was one question that came up a couple of times that I think it would be important to answer. Wired up. I understand, which is very different in the United States, I understand that basically, as far as IIH goes, you all make the diagnosis and then pass it to the neurologist. Is that sort of the general? Yeah, and then I'm understanding, and maybe I should come back and do this course with neurologists, since I am one. And then I understand that the neurologists tend to base their management on the level of the CSF pressure. Okay, that's really wrong. Again, very hard to change behavior, isn't it? But the management of this disorder absolutely should be what is necessary to treat their symptoms and make them comfortable, and most importantly, what's happening to their visual fields. So if they are not co-managing with you or someone to be doing the perimetry, because of this disease being in general okay in most patients, they're not going to blind that many people. But they're going to blind people. This is terrible. I mean, that really should not happen. Yes, sir.
We actually do have one that is doing her residencies in neurology here. Maybe she could answer the question.
The one with Philip's mom. No, it was Philip's mom that done it.
Visual fields?
Huh?
Do you regularly take the visual fields on the patients that have ocular but the intracranial hypertension?
I think we do, but I don't have that many patients with this, so
Anyway,
I don't think I can
I'm
answer
speaking as a
that.
neurologist,
But I don't
so
think
I'm
that
allowed to
we.
do that.
I definitely don't think that we do repeated lumbar punctures to check the pressure.
Yeah, and I don't think you should.
No, I don't think
Right,
that we do.
good.
I
Well,
don't
I'm
know.
glad, I'm glad that's not happening.
But then again, this is
But
from one.
when I
hospital.
trained in neurology, actually in medical school, the first patient I had was someone who was brought in every couple of months for their serial lumbar puncture as a treatment,
Yeah.
and I think that's punitive, right?
Yeah. We
If
wouldn't
you're
do
doing that, you might as well shunt them, if
Yeah.
you need to do that for symptoms. But I think if you can at least educate that visual fields, especially if there is an abnormality on the visual field when you first see them diagnostically, I think you really need to alert your neurology colleagues that this is a disorder that needs attention. All right, we're going to do all the rest of the optic neuropathies in less than 2 hours, right? All right, so here's another case. 37-year-old African-American woman with vision loss in the left eye. 2 normal pregnancies, family history unremarkable. So she has vision loss in her left eye, like a central shadow. It progresses over 5 days. She has pain with eye movements. She has no associated neurologic or systemic symptoms. Her blood pressure is normal. Her neurologic exam is normal. And she's count fingers in the left eye. The right eye is normal in all respects. And she's got a dense, whopping left relative pupillary defect. So we know where the lesion is, right? Here is her normal right eye acutely, and her left eye looks a little normal, except if you compare the two, maybe there's a little bit of swelling. I think you'll buy that. But it's mostly behind where you can see. She's got a central scotoma in her left eye, normal right eye. And so the diagnosis, the location, we have a left optic neuropathy. Everybody's good with that, right? And it's mostly retrobulbar.
Yeah.
Pretty good with that. And we would call this category inflammatory, right? We've got pain. She's a youngish person. Pain is exacerbated with eye movements. So it's isolated. And so idiopathic optic neuritis, right? Okay, this isn't to fool anybody. Tomorrow I'm going to look forward to fooling you lots. But today we're just doing cases to introduce the various categories. So she's got optic neuritis, and if you really didn't know that, you could get an MRI with fat suppression, and here's the normal right optic nerve. Look at that left inflamed retrobulbar optic nerve, normal here, inflamed here. But that's like getting a guaiac on a bloody stool, right? You knew the diagnosis. You didn't need the MRI of the orbit.
Brain.
Why do you need the MRI of the brain?
MS.
Yes, that's why you need the MRI of the brain. Because she's going to ask you all sorts of questions. And her MRI of the brain was normal with the exception of this one, periventricular ovoid lesion in her white matter. And then, what's going to happen with her? Well, we check a few other things on her. You really don't have to, you know. You knew the diagnosis. We have a lot of sarcoidosis amongst our African American population, which is why we do that. And she was treated with 3 days of IV methylprednisolone, 250 every 6 hours. She had 10 days of oral prednisone that followed the optic neuritis treatment trial protocol, right? And 6 weeks later, she's back up to 20/40 in that eye. Wow, you feel like a hero. It's got a relative afferent defect still. Now her nerve is pale. Remember before she couldn't see anything, you couldn't see anything. Now you see everything and she sees everything, right? Okay? And her field is much better. But she's got some questions for you. And you can always just send her to the neurologist. She's got some questions for you. So she says, is it optic neuritis? How comfortable are you?
Yes.
Yes. Okay. That one's an easy one to answer. She says, is it idiopathic demyelinating optic neuritis?
Maybe.
Yeah, with that lesion, I think you could be pretty comfortable. Do I have MS?
I don't know.
Oh, I'm going to add to that, but we're going to follow that one. So you're telling her she has MS. We're going to get into that in a minute, because I bet there's a lot of MS in Sweden. So I'm curious if you use the revised McDonald criteria. And then she says, what's my risk of MS? How should I be treated? You say, okay, I'm going to send this one to the neurologist, right? Because you've got other things to do. You've got to stamp out eye disease like cataracts. So this is the inflammatory category of optic neuropathy. And so let's go to her first question. Is it optic neuritis? And I just want to point out a few things that may trip you up in this differential diagnosis. Okay. So I think the two things that could trip you up is that every once in a while a maculopathy can fool you. And there are other causes of optic neuropathy that may give you a second thought and may make you think it's optic neuritis, but it's not. Okay? So let's talk about the one macular disease that was always the killer was central serous, right? The blister and the layers. And the reason it's a killer is because if this patient comes to an emergency room and they call the neurologist, and God forbid she already has a diagnosis of MS, I can promise you no one's even looking at the macula. And even if they did look, they can't see this. Sometimes you can't even see this, right? And so when you should think about it most often is if you have a male with optic neuritis, right? It's not quite like the IIH 9-to-1, but it's 4-to-1, right? Female, more optic neuritis tends to be a woman's disease. So if you have a male, if you don't have pain, and you have central vision loss, you have got to think about a maculopathy, especially if there's no relative afferent pupillary defect, although sometimes it's like telling things to the children you don't want them to know. But sometimes a maculopathy can be so severe that there's actually a little RAPD. Now, forget I said that. Okay, just there's no RAPD. Think of that. And if you can't see it, I guess nowadays, for God's sakes, it's so easy. Just get an OCT of the macula. So this is mostly for the neurologists that I teach, because they've never heard of this. And so they always think it's an optic neuropathy if an optometrist sent it in, optometrist or something like that. So, okay. Optic neuritis, the optic neuritis treatment trial, remember what it did? It gave you 3 different types of treatment, one not at all, one oral at conventional doses, and IV methylprednisolone a gram a day. And what did it show? Well, it showed that sometimes when you give these patients steroids, you're just treating yourself. Because honestly, if you wait 6 months, there isn't a darn bit of difference amongst those who went and bothered with the IV steroids and those who got placebo. So if the patient wants to get better faster, if they need to have something done, if you need to do something, sure. But don't do oral prednisone at conventional 1 milligram per kilogram doses, right? Because you can make it worse. Right? You have twice the risk of recovery. So everybody gets better, whether you treat them or not. So if somebody's not getting better, that's not typical optic neuritis. So everybody gets better, and as you point out, you have twice the risk of having another optic neuritis episode if you treat with conventional dose oral prednisone. We don't know. We think it's not to do with the route. In other words, there are people who do very, 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 very high dose oral, like taking 40 pills, and they don't seem to have this risk of recurrence. We think it's the dose, not the route, and it's probably something to do with T cells, a certain type of T cell that is wiped out by the higher dose, but facilitated by the lower dose. But I'm just waving my hands. No one has ever figured that out. So, yes?
We did a study on retrospective. It looked at optic neuritis and saw that the route didn't differ.
Right.
Yeah.
Yeah. And
In the outcome, I mean.
Right. And some can argue that maybe your IV is doing something in the brain because it delays MS for a couple of years, but there are better things out there to delay MS. So I think, at least in the United States, it's a medical legal issue. It's a bozo no-no to treat someone with optic neuritis with conventional doses of oral steroids. Why would you, anyway, right? But what the optic neuritis treatment trial, I think, gave us more than anything else was the risk of MS data. It started that whole thing about clinically isolated syndromes, and it showed that the biggest predictor for whether you're going to get MS after an episode of optic neuritis or other clinical isolated event was having even just one classic lesion. Look, just one or more lesion. Your risk at 15 years is up to nearly 75%, whereas having no lesion on your brain MRI, your risk was only 25%. It doesn't mean you're not going to get it, and it doesn't mean you're going to get it. But it's a pretty robust epidemiologic statistic. And I want to go back to the people who said, tell her she has MS. These are the brand new, fresh, hot off the press. The revised McDonald criteria came out in 2017. And it did make it easier to diagnose MS. But the optic nerve was left out once again. So here's our patient. She comes in with an isolated unilateral typical optic neuritis and one classic non-enhancing brain periventricular lesion. Everyone in this room knows this woman has MS. But according to the revised McDonald criteria, she does not. Because although the revised criteria allowed you to include the lesion that was happening at that time, they tell you not to allow to use the optic nerve. They were worried probably, if you talk to the people who wrote this, they were worried that people would misdiagnose non-arteritic angioischemic optic neuropathy or some other cause of an optic nerve disorder as optic neuritis, and so they couldn't do it. But basically, everything else allows for one asymptomatic or symptomatic T2 lesion in at least 2 areas. And it can include the symptomatic lesion, but not if that symptomatic lesion is the optic nerve. So she has 2 lesions, but one's the nerve, so she doesn't have MS by the new criteria. So,
Unless you do CSF.
right, well, no, you still can't, because that just gives you dissemination in time. But you need both dissemination in space and dissemination in time. So you could have just oligoclonal bands in the CSF with her, and she still wouldn't fit the first criteria. Oh, but we know she's got it. Interesting, isn't it? This is a heavy MS country, from what I understand. So, yeah.
I mean, then you delay the treatment.
Yeah, then you end up delaying the treatment. Although in the United States, you don't have to have MS to be treated with the disease-modifying agents, because there have been enough studies that have shown the clinically isolated syndrome and 1 or more periventricular lesions looking like MS. You are allowed to treat them to slow down the acquisition of the diagnosis of MS, but you cannot call her MS in the United States. Or anywhere, according to these criteria. How about that? Okay, now, here's where you come back in. So that was something the neurologists have to grapple with, because I think they really wimped out at the end when they took the optic nerve out of the picture. And it reflects neurologists not being comfortable making the diagnosis of optic neuritis because they've been burned by other optic neuropathies. That's what it is. But here, now you're back in your own bailiwick here. This is where you can be extremely helpful. It's really raised the importance again of the ophthalmologist looking in the back of the eyes. Because there were, at 15 years, there were no clinically definite cases of multiple sclerosis in those patients who started out with a negative brain MRI. We're only talking about that group in which only 25% end up getting MS, but not a one of those with a normal brain MRI and any one of the following ended up getting MS. So no light perception vision, painless, macular exudates, you see the star going all the way around, hemorrhages on the disc or around the disc, or severe disc swelling. They have something else. They don't have MS. They've got an infection, they've got something else. So that's important. Now, a positive brain MRI trumps everything. Sorry for using the word trump. I really try not to use that. So a positive brain MRI, everything's off the table. But for a negative brain MRI, if you find one of these, you're very helpful. And so what usually does this reflect? If you have if you have bilateral disease, if you have any sign of intraocular inflammation, if you've got disc swelling that's enormous, if you've got hemorrhages, you got a lumpy bumpy, you got exudates, you got a star, think of things like sarcoidosis, like Bartonella, syphilis, and tuberculosis infections, or viral infections. They don't have that risk of MS. And that leads us to 2 other new kids on the block regarding atypical optic neuritis. And Randy alluded to this. I assume you all are seeing this now more and more, especially because you can test for it. In the old days, which is no more than a few years ago, I would only think of these entities, the aquaporin 4 or so-called NMO antibodies or MOG antibodies, in someone who had bilateral disease that was severe, or they didn't recover, or it was recurrent. But I think we're learning that that's not always the case, as these antibody tests allow us to expand the phenotype of these disorders. And I'd like to give you this case, because I think it's an important one. So 31-year-old white woman with 5 days of pain on eye movements, left eye, and 3 days of vision changes in her left eye. She has an otherwise normal past history, a little hypertension. She's 20/20 in both eyes. She has normal color vision, but she has a left relative afferent pupillary defect. And here she has this visual field defect in the left eye and a little bit of swelling of the left optic nerve. And sure sounds like optic neuritis, doesn't it? It does, doesn't it? So here's a close-up. A little bit of swelling. No hemorrhages, no big swelling, nothing to worry about. Young white woman with pain on eye movement and an optic neuropathy. Okay? And we even get OCT to show that she's not had any prior events. There's no atrophy. She's got a little swelling on the left. And we get an MRI. And we get the MRI of the brain, right? Because we know that there's an MRI. We know we're going to see enhancement of the orbits, and I'll show it to you in a little bit. But clean as a whistle. So she would be in that no more than 25% risk for MS 15 years from now, right? Everybody's good with that? And here's her orbits, if you want the extra, and she see the enhancement of her left optic nerve. And so, and here it is, yeah, all the way back. So pretty typical, wouldn't you say? I mean, like really typical, like more typical than the one I showed you to begin with. It's just really typical for optic neuritis. She's even white. And so I list all these because most of these would be, the answer would be okay. And I want you maybe to write down what you would do, just for your own sake. You could observe her, right? Because she's got 20/20 vision. She's going to get better anyway. She's got a kid at home. The last thing she needs is to be brought into the hospital for IV steroids. I hope after this you would not treat her with oral prednisone 1 milligram per kilogram for 2 weeks. No, 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 please don't. You could do IV methylprednisolone exactly the way the ONTT suggests. You could do IV methylprednisolone 1,000 milligrams in one shot every morning by a visiting nurse. A lot of neurologists do that. They kind of adapt the ONTT. They adapt it to not even include the oral taper after. And somehow, some way, many neurologists actually do a gram a day for 5 days for some reason. I don't know, just pulls it out of the hat and does that. And there are some neurologists who, knowing that it's the dose, will just give a high dose and for 3 to 5 days. Or something else. I don't know if anybody has something else. So I think that except for number 2, well, oral prednisone high dose.
But how many, what's the highest dose?
So this is usually the dose, because they're trying to make it the equivalent dose to the,
But I
yeah.
guess it's a lot. Here we have 10 milligrams.
Yeah, that's right. So people have to take 100, they have to take usually 50 tablets of the 20s. I mean, it's a lot of pills. It's a lot of pills, but that's what they do, because you really don't want to do that. Or you do nothing, right? So she elects, given all these possibilities, she elects not to have IV steroids. You know, she's seeing fine. She's just kind of got this thing on her there. And 2 weeks later, she thinks her vision has gradually worsened. The pain has improved, and she's now 2800 in the left eye with a bigger left RAPD. Yeah, now it's atypical. Look at the field. So 2 weeks later, instead of getting better, which they should by about 2 or 3 weeks later, now she's worse. And now you start telling yourself, gosh, should I have done something else? Should I have checked something else? What am I doing? So what do you think, guys? Here's her fundus. It actually almost looks a little better, the swelling. Pardon? Yeah, so there's something here that doesn't fit quite as well with NMO as it does with MOG, and I'll show you what that is in a minute. But anyway, here she is, classic mild optic neuritis. This is not recurrent, severe, da-da-da-da. She's MOG antibody positive. And I did get it at onset. But I did only because of cases like her that have burned me, and now I get aquaporin 4 NMO antibodies and MOG antibodies on every optic neuritis I see. because she I would have pushed to come in for IV steroids right from the get-go. And so what should have tipped it off for me was how longitudinally extensive, although remember the one I showed you first, she had pretty longitudinally extensive, but more importantly, you see the sheath enhancing? That's a big tip off of MOG. And so let me just review. I don't know how much you get on this, but this is the new kid on the block as far as neuro-op is concerned. So we're learning about it at the same time. What you should know is that these antibodies are not seen in typical MS patients. So that's one thing you can tell her, you're not going to have MS. I think you can be comfortable. It's found with just limited forms of optic neuritis, but also can give the neuromyelitis optica spectrum disorder, the spectrum. And typically the optic neuritis is by itself in 21%, or can be with the myelitis. The antibody titer does seem to correlate with disease activity, and it's not seen in patients with NMO positive. So if you have someone who is aquaporin 4 positive, do not get MOG. There's no reason to. So if your lab allows you a reflex, you order the one that you think is most likely with a reflex to get the other one if that first one is negative, or if you're stuck the way we are in the United States, because it's a send out to the Mayo Clinic, we have to get both to, they run on both of them, because they're still basically doing research to see if there's ever both antibodies in anybody, and they have yet to find it. It does have implications for management.
Imaging with a spinal cord.
Well, you can, and we did. But a lot of MS neurologists say you should be imaging the cervical spinal cord in every patient with MS, period. So they're going to get that anyway. Consider obtaining MOG antibody in any case of optic neuritis. And of course we have this especially if bilateral, but in any case of optic neuritis, but especially if the MRI is normal. And if NMO antibody positive, you don't need to test for MOG. There's a good response to IV steroids, but flare-ups after discontinuation may move you to PLEX the way you do with NMO. And rituximab tends to be the one that we use most often for these patients, but the Mayo Clinic is now suggesting that maybe IVIG is even better. One thing you do not want to do is the same with NMO, the aquaporin 4 antibodies, beta interferons. So all those drugs used for MS, they make NMO and MOG worse. So it really is important to know that because it changes management. And then this is the Mayo Clinic experience, which really is suggesting that there's an increased risk of recurrence, increase in bilaterality, disc edema in MOG, think about it, longitudinally extensive enhancement, and the sheath in 50% of time, exquisitely steroid responsive, but then it may become steroid dependent. And the question is, do you chronically treat them? And they have a better result with IVIG, but again, the numbers are very small. And so we test for them, not just in these patients. We test for aquaporin 4 antibodies, and because it changes their management. And nowadays there even is, I don't know if you've heard about the new treatment for NMO, extremely expensive, but it's very expensive. But and it's more expensive than rituximab, and rituximab is expensive. But it's the first, you can see by the fact that it's in the New England Journal of Medicine, it's the first FDA-approved drug specifically for NMO. Remember, we use rituximab because we know about it from rheumatologic diseases. And then we always now get MOG antibodies with inflammatory optic neuritis. All right? Yes?
What about plasmapheresis in this patient?
Yeah, PLEX, exactly. So in this patient, she actually did get IV steroids. She responded a little bit, and then she moved on to PLEX. Yeah, we do plasmapheresis. Okay, I think you can argue for it for the aquaporin 4. There's enough literature of how bad they get. The MOG, it's kind of hard to know whether you want to bring out the big guns, because plasmapheresis the access and everything. A lot of these patients get infections. It's not easy stuff. All right, next case. 67-year-old man notes the sudden onset of blurred vision in the superior field of his right eye upon awakening in the morning. He has no headache or orbital pain or discomfort. His visual acuity is 20/80 right eye, 20/25 left eye. He has an inferior visual field defect on the right and a right relative afferent pupillary defect. And here are his. So you see swelling here. Take a look at that. There we go. We've got a disc at risk on the right. So what do you think in his diagnosis is?
Nine.
Okay, so we have a right non-arteritic anterior ischemic optic neuropathy. So tell me historical questions that you absolutely want to know about this guy. So let's first take what Randy said to you. This is an older man who has an anterior ischemic optic neuropathy. So you absolutely, the first thing you have to do is rule out giant cell arteritis, correct? So you're going to pull out of your pocket your symptoms of giant cell arteritis and you're going to ask him, and I'm going to tell you he doesn't have any of them, okay? All right, so now, what other historical features do you want to ask him?
Joint communication.
Yeah, so now we've done all the GCA. Sleep apnea.
Hypotension.
Okay, well, we'll talk about that one in a minute. The nightly medication of hypertension. I don't know if you're being taught that because Randy was here, but we'll talk about it. Viagra, good, or Cialis, or hormone-enhancing drugs. Yeah, well, that's a pretty good one. Okay, one other thing.
Diabetes.
It's a medication.
All the metabolic receptors.
Yeah, there's a medication you're missing. You're very good. You've got 2 out of 3. I'm very impressed. I really am very impressed.
Hypertension medication.
No, and let's deal with that hypertensive medication at night. Charade. Where's Randy? He's not here. Okay. This all comes from Sohan Singh Hayre. God bless him. The man is still writing 10-page articles at age 89. And he is wonderful, and he is fabulous, and he has moved our field so far forward. Yes?
He's even 92.
92, even better. And he did another one just came out. And he has contributed unbelievably to this disorder. But nobody owns a disease. And so, not everything they say is correct. His hypothesis is that AION happens in the morning, and he relates it to taking your blood pressure medications at night, and therefore it's a modifiable risk factor. Have them take their blood pressure medications sometime in the day, and this is all due to hypotension during the night, and then they wake up with it. And he bases that on the fact that he says everybody who gets this wakes up with it. And this person actually did. So, other people have then done blood pressure recordings through the night and have not shown that people get a drop in their blood pressure from taking their blood pressure medications at night more than what we all get at night. But you could still argue, well, that's why it happens in the morning. So we have the ischemic optic neuropathy decompression trial, in which we tried doing optic nerve sheath fenestration to stop, help patients who've had AION. Of course, it was a negative study, it didn't help, it hurt, so nobody does that anymore, thank goodness. But what it allowed us to do was look at the natural history of 400 plus patients with non-arteritic anterior ischemic optic neuropathy. And one of the things we asked them, and remember, to be enrolled, you had to be present within 2 weeks of the onset, so it's fresh in their mind. One of the things we asked them is, what time of the day did this happen? What time of day? What's the hour that you noticed it? And remarkably, if you look at any particular hour that happened the most, 1/3 of patients said that it happened at awakening. But if you think that people sleep for 8 hours a night, and 8 is 1/3 of 24, there was no increase. All the rest of the day was completely spread out like any distribution that you would imagine. And so I take issue with that, because I have seen people been taken off their blood pressure medications, things have been mixed around. I just think you need to be a little bit always question what you're told. So I think the ischemic optic neuropathy decompression trial really showed me that not everything a brilliant person says is true. Okay, so let's anyway, you're missing one thing. I heard the performance-enhancing drugs like Viagra and Cialis. I heard obstructive sleep apnea. There's one more. It's a medication.
Nitroglycerin.
What?
Nitroglycerin.
No. You're going for that blood pressure drop thing again. I don't know. No, this is good. What if I told you he had atrial fibrillation? Which many of these patients?
Boron.
What's the drug that they're on for atrial fibrillation?
Boron.
Ooh, no. You're not aware of this. That's very interesting. Okay. A drug called amiodarone? Acerone? So, he has a history of atrial fibrillation, has been taking amiodarone for the last 2 months. He used Cialis the evening prior to awakening with blurred vision. And he has had difficulty sleeping for several years. His girlfriend, 45 years old, he's 60-something, states that he snores heavily and seems to stop breathing at times. Okay? So these are the 3 risk factors that you really need to ask, because they are not good. They almost never will offer you, when you ask them their medication list, they're never going to tell you about the performance-enhancing drugs. If you don't know that amiodarone is related to something that either is NAION or looks like NAION, at least in the United States, you're up for a $1 million lawsuit when the other eye goes, whether it really was the amiodarone or not. And sleep apnea, again, you're going to have to specifically ask. Shall we talk? Let's talk. All right, we're going to do each of them. So amiodarone, it was developed in the 1960s for treatment of angina. It was initially used in patients with severe life-threatening ventricular tachycardias, and in the PDR, and what the FDA has approved, that's the only thing that's in there. However, it is one of the most effective drugs for atrial fibrillation. It is used by cardiologists worldwide for AFib. And it has a long, long half-life, up to 107 days. So when it's in your system, it's there for a long time. Ocular symptoms occur in about 10%. If you look with the slit lamp, you should be able to use the findings of amiodarone corneal changes to know whether the patient's even compliant, because they're always there, the whiskers in the cornea. In about 1987, someone took a look demographically about patients having anterior ischemic optic neuropathy and whether they were on amiodarone, and 13, so about almost 3% of patients had NAION who were patients on amiodarone, but you could argue, well, if they're on amiodarone, it's because they have atrial fibrillation, so they have all sorts of other vascular risk factors, so that's not really fair, and maybe it's just run-of-the-mill NAION. However, it's not that common to have bilateral NAION at the same time. And it also, the amiodarone, AION, or whatever you want to call it, can last for months and months, the swelling. But anterior ischemic optic neuropathy, it should come, it should be there a few weeks and then go away. And it shouldn't be simultaneously bilateral. And so it has been brought up that there is a toxicity of amiodarone to the optic nerve, and that this is a toxic optic neuropathy. You could also argue, if there's an old Saturday Night Live line, stop, you're both right. It's both a breath freshener and a floor polish. Right? So it is possible that the amiodarone is toxic to the vasculature. On pathology, you see vascular changes too. So maybe it precipitates AION in the susceptible person. Either way, if someone has one eye that looks like an AION happen, and they're on amiodarone, in the United States, if you do not at least have a discussion with the patient and the patient's cardiologist about the possibility of discontinuing that medication, you will be sued if the second eye goes. And, you know, whether it's right or wrong, it's just something, again, like McDonald's and obesity, you're probably going to get our litigious system one of these days too. So it doesn't really exist, or is it a risk factor for NAON, a susceptible person? And what is standard care? Nobody is asking us to screen for a disc at risk. However, you could imagine maybe that would be something to do. In my experience, the cardiologists find something else for them to be on without any problem. So I think having that conversation is very, very important. Now, what about Viagra, Cialis, and all of those? So this was the article that gave, this one here, gave the Journal of Neuro-oftalmology its biggest impact factor ever. And it went up and back down. Because everyone was quoting this article because it was by the New York Times and everything else became very she to be looking for this. And basically what it suggested was that there is a risk, and maybe it's via low blood pressure, I don't know, but that there is a risk for developing NAION in patients who are taking these performance-enhancing drugs. And then Andy Lee and I, in our infancy, decided to look epidemiologically, and it's hard to know how many people are taking these drugs because they can get them even without a prescription sometimes. And so it turns out that if there really was an association, we said, then there should be so many more NAIONs out there because there are just so many people taking these drugs. So we said, no, there's no association. And then the FDA made Pfizer, the company, do its own study. And sure enough, there was an association. And of course, it was published in the highly read Journal of Sexual Medicine in 2015. So nobody really saw it. But indeed, there is a risk, almost 4 times greater risk of AION if you have taken a performance-enhancing drug within 1 week of that. So again, it's something to ask about, and then your patients can choose the lifestyle they wish.
Yes.
And then sleep apnea. Daniel Mojan in 2002 was the first to suggest this association, and he found that 71% of NAION patients had sleep apnea versus 18% of controls. Again, he postulated that it had something to do with nocturnal hypoxemia from relative apneic spells, and then it happened. And this, of course, is the most recent article and probably the most cited and most reasonable. And indeed, there is obstructive sleep apnea. It's common in patients with NION. And you should at least ask the patients about them, because if it's not going to stop the other eye, there are several patients who, even on CPAP, had NION in their other eye. At least there are so many other medical problems that go with obstructive sleep apnea, it's worth asking them if they come in with NION. Yes?
Is there a correlation how severe that apnea is, or?
No, I don't think so, actually. Let's look here. So, yeah, they did find that non-adherence to ventilation treatment with CPAP in patients with severe obstructive sleep apnea increased the risk of second eyeball. On the other hand, there are many case reports and other things that have suggested that even using CPAP, you can get second eyeball. So you were right. That was the vascular category. A couple more things about ischemic optic neuropathy. You not only can get anterior ischemic optic neuropathy, but you can get posterior ischemic optic neuropathy. But that's a diagnosis you make at your peril. You better be sure you get good imaging of the optic nerves with fat suppression and gadolinium, that you're not missing an infiltrative or compressive lesion or an optic nerve sheath meninge, something like that, because it's very rare posterior ischemic optic neuropathy. What's the top diagnosis that you should think about? Absolutely. It's GCA until proven otherwise. Okay? And indeed, this arteritic versus non-arteritic, you had a whole 45 minutes out on it. Rule out giant cell arteritis with sedated CRP platelets in all patients over the age of 50 with ischemic optic neuropathy of any kind, AION or PION. And arteritic can be AION or PION. It can be occult in up to 25%, and You know all that stuff already. So the classic non-arteritic AION, older than 50, a little bit more male than female, and the classic inferior arcuate defect, and of course, due to ischemia to the front of the optic nerve, and therefore you're going to see a swollen disc. And the swollen disc can be segmental, it can be diffuse, and then ultimately you get this pallor often in the segment that corresponds to the inferior arcuate defect. And I heard from the front, almost always happens, 95% of cases of AION, non-arteritic AION, have a small cup to disc ratio, the so-called disc at risk. And so you really have to look for that. If you don't have that, think about other things, especially giant cell arteritis. Now, there are some things about non-arteritic AION that are unusual. If you're thinking of this as a small vessel vascular disease, there are things that are unusual. So first of all, Sohan Singh Heyre has a patient as young as age 11 with non-arteritic AION. My youngest patient is something like 27. You can have this disease in young people, and vascular disease tends not to happen in young people. You can have some discomfort, believe it or not. And it progresses over days, sometimes even weeks, which isn't usually what a stroke, as you think of strokes of the brain, does. That probably all has to do with this compartment syndrome idea, that you've got this tight little opening, this tight little crowded nerve. Recurrences in the same eye are rare. Maybe by killing off some of the fibers, you have now more room in that front of the optic nerve, so it tends not to happen. And up to 27% of these patients can improve. The number you're often taught from the IONDT is 42 or 43% can improve by 3 lines or more in 6 months. The reality is they were only taking those patients who had bad enough vision to know if they could get better. So if you take the whole group in which more than 50% were actually 20/64 or better, the improvement rate is about 27%. Recurrences, we said, and the bilaterality rate is only about 15% at 5 years. It's worse with younger people, probably because the crowded optic nerve head is more important. And vascular risk factors occur only 60% of patients. So again, it's something more local. And it's all to do with that disc at risk. We did a study, and although, of course, if you're talking about a tertiary care center, you're going to have referral bias for the really unusual cases, right? 23% of our non-arteritic angioscopic optic neuropathy patients were under the age of 50. And that's probably because we're getting patients who rule out optic, they were young and they thought, gee, it's a funny optic neuritis we're getting. It turns out it's AION. But I think it's important to know that you should at least consider that diagnosis. And a study done by one of our, then became our fellow and one of our old fellows, looked at the issue of misdiagnosis of optic neuritis. And again, a tertiary center, right? So these are all, the slam dunk cases are not going to be sent there. But indeed, out of 122 cases sent to them as optic neuritis, only 40% were actually optic neuritis. And amongst the 60% that were not, the majority were non-arteritic anterior ischemic optic neuropathy in young patients. So think about that possibility.
When you say optic neuritis, you mean only the myelinated
Yes.
neuritis?
Yes. And if you think you know how you can separate the two, it has nothing to do with the rate of visual loss, the range of acuities. And in the patients who we saw under 50 years old, the thing that I will point out that I think is important is they tend to do better acuity-wise, but their second eye is involved way more often than the 15%, suggesting again it has a lot more to do about the optic disc being crowded because they're going to be made the same in the 2 eyes. So if you're looking at the AION versus optic neuritis question, you're right. Think of AION in the older patients. If you've got a male, think twice about optic neuritis. Pain is infrequent within AION, so if you're not having pain, again, question optic neuritis. You have to have edema for us to be making this discussion. So that's only 1/3 of cases with optic neuritis, right? The other 2/3 are retrobulbar. So we're only talking about the differential between an anterior optic neuritis and an anterior ischemic optic neuropathy. If you still don't know, you can get an MRI. Typical optic neuritis, the nerve will enhance acutely. Non-arteritic AION, it will not. So that may help you, and ultimately you can wait because typical optic neuritis will get better, but NAION will not get better to that degree. And I think that's important, and the reason it's important is because now that we have medications to hold off MS in patients with optic neuritis and a brain lesion, this poor patient who had this little ditzel here, who had NAION, was told she had MS. She's 37 years old and was treated with these agents. And what she really had was non-arteritic anterior ischemic optic neuropathy and a ditzel. So it's very important because you are the ones who are going to send the patient to the neurologist. You have to make the right diagnosis. I'll bring up one other, we'll stop for a break. I'll bring up one other cause of ischemic optic neuropathy that you should be mindful of, and that is perioperative ischemic optic neuropathy. These are patients who go into usually elective procedures like prone spine surgery that lasts a long time, or not so elective procedures like CABG, coronary artery bypass graft surgery, and they wake up blind. And they wake up blind either from bilateral anterior ischemic optic neuropathy, most commonly that's the setting of CABG, the coronary surgery, or bilateral posterior ischemic optic neuropathy, and most likely that's what you'll see in the prone spine surgeries. And a registry was done in that, and indeed the vast majority of these occurring are spine and cardio. And most of the time, these are going to be PION, like I said. There's a 10% or so that have a central retinal artery occlusion. Those are the patients whose headrest was bad. Sustained pressure on their globe, which blanched their central retinal artery circulation. That's different. These people, it happens even if they're in Mayfield pins with nothing on their eyes. This likely is a venous congestion problem. There's been a number of lawsuits about this in the United States, suing the anesthesiologist for letting the patient be too hypotensive or too anemic. Studies like this, which have actually done case control studies, have found no difference whatsoever in the level of blood pressure drop or the level of hematocrit drop in those who undergo the spine procedure, who lose vision, and those who don't. The differences are actually 6 factors: male gender, obesity, a Wilson frame, which puts the head lower than the heart, longer duration of the procedure, greater estimated blood loss, and lower percent colloid and more crystalloid, suggesting that the process actually is more of you're on your face, you lose blood, it's replaced by crystalloid, it diffuses out of the tissue and causes venous outflow obstruction in your orbit and from your nerve, and that is probably a venous infarction. And no matter how high you put the blood pressure or put the hematocrit, that's not the problem. So again, I've been talking a little bit too much perhaps about litigation, but in the United States, if an ophthalmologist or neurologist puts in that this happened because of low blood pressure and anemia, and then the anesthesiologist is brought to court, the reality is we don't know 100% why this happens, and it's absolutely devastating. All right, I think I can fit. What time are we supposed to break? I think it was like 5 after 4. Was that?
No, 4 o'clock.
At 4? Good. This will be a good one to just quickly end with. So, 51-year-old woman with vision loss in her left eye. She has breast cancer for 11 years, 11 years ago, lumpectomy, radiation chemotherapy, negative lymph nodes, and she is felt to be cured. She has hypertension, borderline diabetes, migraine headaches, and there are her medicines. She's followed by a neurologist for episodes of tingling of both legs and occasionally left arm shaking. So she even had a neurologist. And she's had a normal brain MRI, and she was scheduled for an EMG. And then she sees her ophthalmologist, the same ophthalmologist, for an annual visit. Hadn't seen him for a year. And he notes when he's testing her vision that she has decreased vision in her left eye and she has left optic nerve pallor. And so with all these other neurologic things going on, he diagnoses her as having a left optic neuritis and sends her back to her neurologist. The neurologist cancels the EMG, repeats the brain MRI, it's normal, and plans a lumbar puncture to look at her CSF for oligoclonal bands for possible multiple sclerosis. So the patient panics, refuses the LP, and seeks a second opinion with you. So, your neuro-ophthalmic exam, she does have decreased vision, decreased color vision in the left eye, and a left relative afferent pupillary defect. She also has pallor of her left optic nerve, certainly no disc at risk, right? So it was not an old NAION. And here's her visual field. So she has a left optic neuropathy. And it had to have happened sometime within 1 year ago, and 6 weeks, or probably more given how pale that is, 1 to 2 months ago. We're good with that? Okay. And so, what do you want to do? It's a left optic neuropathy, incidentally found, and there's no pain. Well, how about we just look at the MRI she had? Should we look at the MRI she had? Let's look at the MRI she had. So, here's the MRI she had, and it was a brain MRI. And the nerves look, I think you can see that it looks pretty good. Okay? So, let me look. Here's the T1. And I'll even give you contrast. There it is. Okay, so what's wrong? This is exactly what our man up in the second row said. Okay? What's wrong? He got a brain MRI. How much of the optic nerve are you going to see in a brain MRI? About the 2 or 3 millimeters intracranial, right? You got all that stupid white fat in the way in the orbit. You need an orbital MRI with contrast. Well, still looks with fat suppression. Okay? And look what she's got. She's got an optic nerve sheath meningioma. Look at that. Isn't that beautiful? She's told optic neuritis. Okay.
Can you show the first MRI again, please?
Yes. Let's go back. Even in retrospect, you really can't see it. Brain MRIs are not good for the optic nerve.
But I can't see a swelling in the...
Even in retrospect, come on. You're saying you see it here?
I'm talking
Not
about
here.
the pupil. You go one slide more forward.
There.
There.
Yes.
Where?
It's like at the left. You can see it's like a little bit swelling. Maybe the next
No,
one also
no,
shows
that's
it.
normal.
Can you go to the third one? Here, we can see difference.
No.
Anyway.
No.
Okay. At the pupil.
All right. Remember, doesn't have swelling. She's got a big, almost cupped nerve on that side. Okay. So we're going to stop there. We're going to come back to compressive optic neuropathies. All right. Remember, this is the last 15 minutes of bread and butter. Tomorrow, whoa, we got good stuff. You think this is easy? All right. So that was an example of compressive infiltrative optic neuropathy, and you know what? There's not a lot to say about it, so I'm only going to mention a few things. Typically, it's painless. If it's an insidious, slowly progressive worsening, everybody thinks about it. But I would venture to say that just as frequently, it's a sudden awareness of vision loss. It's not sudden vision loss, but a sudden awareness of vision loss. So beware of the person who says, I had vision loss yesterday, you come in, they see a pale nerve. It's just maybe one central fiber just got involved, or maybe they were a pirate for Halloween and they happen to use only one eye, or they look at a microscope or something. So the same meaning for slowly progressive vision loss and sudden awareness of vision loss in the setting of signs of chronicity like paleness of the nerve, that should signal to you a compressive or infiltrative process. And it can be any orbital mass, it doesn't need to be neoplastic, it can be a thyroid mass, it can be any orbital apex lesion, doesn't need to be neoplastic, it can be a fungus, a mucor, and any intracranial mass or infiltrative process that gets the anterior visual pathways. And who are the biggest contenders in this? So the one that gets missed the most is the case we just saw, an optic nerve sheath meningioma. Think about the misdiagnosis of optic neuritis in a middle-aged woman, slowly progressive, you see paleness. There often is disc swelling if it's anterior enough with these shunt vessels, which are basically hemorrhoids on the disc, right? These are veins that are usually thin, and because the outflow is being blocked, they open up and they're just little hemorrhoids. You have to get fat suppression with gadolinium, and you'll often see this tram-tracking appearance. Now, to the point where this is pathognomonic enough in the right setting that most radiation therapists will treat these patients without a biopsy, because if you biopsy them, you're likely to worsen their vision because of the peel arteries that go through the mass to the nerve. So if it's a classic enough presentation like this, and radiation not only stops progression very well in these patients, but in about 50% of cases may actually make them better. So it's a win-win. Optic nerve glioma, benign if it's in childhood. Beware of the very, very rare but very, very nasty optic nerve glioma of adulthood, which often presents like an atypical optic neuritis, even with pain and swelling of the nerve, but you can usually tell what it is on screening. Ophthalmic artery aneurysms are actually the third most common cause of compressive optic neuropathies. So think about that. And then sphenoid wing meningiomas getting at the orbital apex or the intracranial optic nerve. But the reality is the most common cause of a compressive optic neuropathy is actually pituitary tumor, just because pituitary tumors are so common. And you can imagine that if the chiasm in an individual is a little further back, so that when the pituitary grows up, it hits one nerve or the other or both, you'll get an optic neuropathy rather than a chiasmopathy. So think about pituitary tumor when you think you've got a compressive optic neuropathy. So the only new thing I would say is basically to tell you, to reiterate what Randy had to say about OCT. We follow a lot of these patients. So I was telling someone before that the primary care neuro-ophthalmologist sees IIH patients regularly and pituitary patients or other compressive optic neuropathy patients because we follow them for the neurosurgeon to know if there's recurrence and to what's going on with their visual function. But the other thing we can do for them these days involves OCT. And everyone knows about, thinks about the chiasmal compression of a pituitary tumor. In this case, you have chiasmal compression of both, of the chiasm, and then you also have compression, in this case, of the left optic nerve, as you can see here. And what OCT has done, first, we learned from the first set of OCTs that you can use the RNFL to show this kind of compression, and we even had cutoffs that if it were below 70 or below 60, the chance of having vision recovery after decompression was less, and this would be very helpful for the neurosurgeons. But it's the GCC analysis which has really revolutionized this for the neurosurgeons, and we've got several articles in their literature now about that, because you can actually, remember the thing I showed you with the left optic nerve compression and chiasm? Here's your nasal field, your nasal ganglion cell dropout in both eyes, which gives you your bitemporal defect. And here is the left optic nerve. Remember, it was an inferior visual field defect more than superior, the involvement there. So you literally can see the visual field if you just flip it upside down and backwards. And I think the other thing about the GCC, look at this case, normal visual fields. You see this tumor pressing, and the neurosurgeon wants to know whether it's doing anything or not, because if not, they'll just watch it. And the visual fields are normal, and the RNFL was normal. And in the old days, we would have said, no, it's not doing anything. Look at the GCC. And it's either because it's more sensitive, which I think it is, to chronic compression, but it also happens faster. So it'll be abnormal in 3 weeks as opposed to the RNFL, which will be abnormal in 6 weeks. So this is very, very helpful for the neurosurgeon. But before you get the idea that, forget it, I'm not going to do visual fields anymore, I'm just going to do OCT. Remember, even the GCC lags behind. And here's an example of a patient with a florid bitemporal defect, big pituitary tumor, normal RNFL and normal GCC. Why? It's pituitary apoplexy. It just happened. And the function measure, the visual field, which is a measure of function, will happen before you'll see a measure of structure be abnormal. So you need both. Yes?
Oh, I mean, how long?
There's like, yeah, no, there's like 2-3 days of it before. So we need both. And it's great. Now we've got function and structure, right? Okay, 35-year-old woman with blurred vision. Her past medical history, asthma and pulmonary tuberculosis. She was treated with isoniazid. Her liver function test became abnormal, so she was changed to rifampin, pyrazinamide, and ethambutol. I told you these were not hard cases. They're just eating into the conversation. Okay, so 1 month after her medication change, images were bright and hazy. She lost contrast. She had progressive blurring. It made her have to stop work. No associated headache. And on exam, 2100 right eye, 2400 left eye. She had dyschromatopsia, poor color vision in both eyes. Her amyloids were blurry, and she had normal fundi. And here are visual fields, which for all the world look kind of bitemporal-ish, don't they? But you know what she has, right? Ethambutol toxicity, which, but just to be sure, she gets an MRI, which is normal, and the ethambutol is continued. She gets back to 2050, 2075 and then back to 2030 in both eyes, but still has some color vision problems 11 weeks later. Here, her fields have indeed improved. It's interesting, this almost bitemporal look. Part of it is that the mechanisms for testing on the Humphrey perimeter, or all these automated perimeters, they're done for glaucoma, and so they test over meridians a lot, and it looks falsely bitemporal when they have secocentral defects. So part of it is an aberration of how the visual field tests, but part of it is probably that in ethambutol, the chiasmal fibers are involved from each eye. But we know it's more than that because their central vision is out as well. And so here, she ultimately has developed quite the pallor of her optic nerve. So this is ethambutol toxicity. I assume someone said to me that you don't really use amiodarone here. I assume people get exposed to ethambutol here, right? Okay. It is partly a dose-related toxicity, and it is partly a idiosyncratic reaction, even to low dose in about 1% of patients. Usually the patient's been on drugs for more than 2 months. The chiasm is affected early, color vision is affected early, and it's reversible, but only in about 50%. So people can really have residual deficits. And depending on your country, there are different screening strategies when patients are placed on ethambutol. And so this is the toxic nutritional category, and this is basically 2 slides. I just want to be sure that if you think of these things, always, you've got someone with especially bilateral optic neuropathy, you're not sure what it is, go back to the medication list. In our country, unfortunately, the electronic medical record, the medication list just gets brought forward, or it gets done by a tech or a nurse. Doctors actually asking a patient what medicines they're on, that never happens anymore. and you can get burned. So first of all, the nutritional, metabolic ones, one to remember the most, vitamin B12 deficiency, copper deficiency, especially if people are using a lot of denture cream, which has zinc in it, which leaches the copper. Tobacco, especially cigars and cigarettes, can give an optic neuropathy or precipitate an optic neuropathy in patients who are nutritionally deprived especially. It's typically progressive, bilateral, symmetric, with color vision problems. Secocentral scotomas is the classic. And acutely, the optic nerve can look normal for a very long time. It's like Leber's hereditary optic neuropathy. It's sort of a hyperemic kind of metabolic hyperemia that masks the dropout of fibers over time, so they don't tend to get pallor until a lot later than these other optic neuropathies. And it also may make the nerves look a little swollen. And the meds to remember are ethambutol, that's top of the list. Linezolid is an antibiotic often used in cystic fibrosis patients. It also is a dose-related, can have a little bit of mild disc edema, and it has an associated peripheral neuropathy. Amiodarone we've beaten to death, especially since we don't see it, so we'll let it go. The PDE5 inhibitors precipitating AION, methanol and ethylene glycol, toluene glue sniffing, and then if people have had their hip replaced in the early 2000s, there was a certain type of hip replacement that when it degenerates, like 5 to 10 years later, will release cobalt, which is toxic to the optic nerves. And again, it's a good history to pick that up in someone with unexplained bilateral optic neuropathy. And that's it for that category. So we have only one category left, and I've got how long? 35 minutes, right? Oh, this is my favorite. So this is the case of a 20-year-old white man with vision loss in both eyes. Past medical history unremarkable, family history unremarkable. He's a college student but insists he does not use alcohol or recreational drugs. And he's got a really funky history. At age 8, he had his first routine eye exam, and something was found in the appearance of his optic nerves was really weird. It looked like swelling, but the person who saw him was smart enough to not mess with normal function, and he was asymptomatic, and so they just observed him yearly and it never changed. But at age 20, 8 months prior to you seeing him, he had sudden painless vision loss in his left eye, down to 2200, with swelling of the left optic nerve and this visual field. He had an MRI of the brain and orbits, which was normal. He had blood work, as you see, which were all normal or negative. And then, unfortunately, 6 months later, he had vision loss in the right eye. He's now 2100 right eye. He's down to count fingers in the left eye. And then remember what I said about that strategy. It's a little concerning. So, you know, I would have repeated the MRI in the setting, and they did, and it was normal. And he had more blood tests that were normal, and he had a lumbar puncture with a normal opening pressure and normal CSF contacts. And when you see him, 2 months after the second eye, 8 months after the first eye, he's count fingers in both eyes, has a relative afropupillary defect in the first involved eye. He's got these visual fields and this fundus. So he's pale in the first eye, with a little bit of something here, and he's pale, beginning paler here, and this kind of angry-looking disc.
It's not Saderusian.
Libers.
No.
Right? So what might you do right there in your office
Ultrasound.
that would give you the diagnosis? Not ultrasound.
No,
Will give you the diagnosis.
Complicated.
No? No family history. Good luck. What? Someone said something else. What is a test you could do in your office as an eye doctor? I can't say that to the neurologist, but you have something you could do in your office. And when I went to Cuba back in 1992, We had the epidemic down there. We were checking a family with this disorder, with acute vision loss, and we did this test right there, right in the room. Fluorescein angiogram, right? Because this looks swollen, doesn't it? But what happens in a fluorescein angiogram with real disc swelling? What will you see? Disc swelling from any kind, papilledema, AION. It will have late leakage, right? Look at this one, no late leakage. A little bit of staining, but no late leakage. So what do you think he has?
Leber.
You think he has Leber hereditary optic neuropathy, right? Okay, so you send for the 3 primary mutations, which account for about 90% of cases, and hey,
It can be negative. It can be negative.
no, stick with your guns. What did I just say?
It can be negative.
He's got labors. Of course, he's got labors. So those 3 mutations account for 90% of labors, and it may be the only sequencing you can get done commercially, but you can sequence the entire mitochondrial genome, and he had a new mutation that had not been reported before. He had labors. It's classic labors. Don't ever question your own diagnostic acumen. You had it, all right? And so we're going to talk about the hereditary optic neuropathies, and I've left the whole 30 minutes for this because this is the best stuff. Randy kept saying I was going to talk to you about it.
There's different
No, we'll talk about it. All right. So let's talk about the hereditary optic. Yeah. Yes, regarding the leakage. Why does it not leak? Labors doesn't leak because it's not true swelling. Leakage, real disc edema has late leakage because the there's just staining because he had an arc around his optic nerve. Yeah. All right, so the hereditary optic neuropathies, in general, when you're done with them, they are usually symmetric, with central vision loss, color vision problems, and ultimately optic nerve pallor, typically in the distribution of the papillomacular bundle. There are basic ways of categorizing the hereditary optic neuropathies. You can have the autosomal dominant variant, autosomal recessive variants, and then maternally inherited via mitochondrial DNA. And just to remind you all about those, so here's autosomal dominant, right? You have an affected, in this case female, passes it on to half of her children, both male and female, and a male could pass it on, and this female could pass it on to half of their children. That's autosomal dominant, right? Has no gender predilection, and anybody can pass it on. And then we have autosomal recessive, which is typically where you might have consanguinity, and you've got the 2 people who have a recessive gene and they're not affected, and about 25% of their children will be affected when the 2 go together, and another 50% will carry the gene on to the next generation, right? And so to show up, you've got to have both people having a recessive gene, and you have to be unlucky because it's only 25%. So that's recessive. There's also recessive sex link. Did you know that? Mitochondrial happens because, unlike Mendelian genetics, in which we're talking about nuclear chromosomes with half our chromosome from mom and half our chromosome from dad, the mitochondrial DNA, and there are hundreds of little circles of them in every mitochondria, and we have hundreds of mitochondria in every one of our cells. The mitochondria live in our cytoplasm, in our soup. And all of our soup comes from mom, right? The egg's there, the sperm comes along, spends all its mitochondrial energy just inserting the nucleus, and then it goes away. The only thing it contributes is the nuclear DNA. The mitochondria come from mom, and therefore our mitochondrial DNA come from mom. And therefore, if you have a woman who has a mitochondrial DNA abnormality, every one of her children will get the disorder, or will pass it, will have the defect. But only the females will pass the defect on to the next generation. There is no inherent sex difference in mitochondrial phenotypic expression. There's nothing about the genetic defect that says that men or women will show it more often. But women are the only ones who can pass it on to every single one of their children. Okay? So that's... Now, when we talk about mitochondrial diseases, there's something really cool that goes on. If you think about our mitochondria as little bacteria with their own circular DNA that somehow, some way got slurped into the proeukaryotic state in evolution. What we have in every one of our cells is we have mitochondria that have its own DNA in circles. And that DNA codes not only for proteins that are important for oxidative phosphorylation and other mitochondrial function, but it codes for all the proteins necessary to make ribosomes and to actually make those proteins right there in our own little factory. So the mitochondrial DNA basically does everything for itself in the mitochondria and makes these red proteins here. But 90% of the proteins that are necessary for a mitochondria to function and to work well are actually coded for on nuclear DNA, on the chromosomes. And when that protein, that RNA is made, it has a little tag on it. So when the protein is made in the endoplasmic reticulum, that tag says, take me to the mitochondria. And that protein knows that it is to be transported into the mitochondria or the mitochondrial membrane, and it is important for mitochondrial function. So a mitochondrial disease can occur from a defect in mitochondrial DNA or from a disease in a gene in the nuclear DNA whose protein is destined for the mitochondria. And that's why you can have mitochondrial diseases that can be inherited maternally if they're due to mitochondrial DNA abnormalities, or Mendelianly if they're due to nuclear DNA abnormalities. Pretty damn cool, right? And what's really also cool is that some of the proteins coded for in the nucleus are not just proteins necessary for oxidative phosphorylation. Some of them are proteins that instruct the mitochondrial DNA when and how to replicate. And that's why with the CPEO syndromes, which I'm not going to get into, they're nuclear inherited, but they have mitochondrial mitochondrial DNA abnormalities because when the mitochondrial DNA goes to replicate, the protein coming from the nucleus is wrong, and so they replicate wrong and they end up losing Pac-Man-like bites from their DNA. So that's how you get mitochondrial disease. So the prototypic optic neuropathy that is a mitochondrial disease that's due to mitochondrial DNA abnormalities is indeed Leber's hereditary optic neuropathy, which is typically a subacute, sequential, or simultaneous bilateral central vision loss. The age of onset, you're all taught, is typically between 18 and 30 or 15 and 35. But we now know that with molecular confirmation, we have people losing vision from Leber's as young as age 1 and as old as age 87. So it should never leave your differential diagnosis. It has a male predominance of 80 to 90%, which is not explained by maternal inheritance, by mitochondrial DNA inheritance. There must be some factor likely protective on the X chromosome which makes men more susceptible to showing the phenotypic expression because they don't have 2 copies to protect them. But the actual locus has never been found. Each eye progressively worsens over weeks to months. There is a recognized interval between the two eyes in 50% of cases, and that can be anywhere from days to months. However, more than 97% of patients will have the second shoe drop, the second eye involved, by 1 year. So it's a devastating disease. The acuity is usually worse than 2200. Color vision is affected early, and they have these big central defects, secocentral to begin with, and then big central defects. Initially, you may see the so-called typical classic fundus appearance of acute vision loss of Leber's, which is this hyperemic tortuosity with these little telangiectatic vessels. It looks like swelling, but it doesn't leak. But in nearly 50% of cases, this is a person having acute Leber's vision loss, and the optic nerve looks completely normal. Ultimately, they develop pallor, usually in the papillomacular bundle. For some patients, some individuals can have spontaneous recovery. It depends primarily on which mutation they have. It can occur years later in the form of a tiny little hole in their big scotoma. We called it a bagel or a donut scotoma, where one day they may just wake up and see 20/20. This can occur in as few as 4% of cases. With the 11778 mutation, it's probably more like 18%, depending on how you define it. It can occur in up to 70% of patients who have the 14484 mutation. So knowing which point mutation they have is important. Then, within each category, the 11778, the 14484, you are more likely to be in that 18% or that 70% if you lost vision before the age of 20, and especially if you lost vision before the age of 10. So it's kind of a catch-22. You can lose your vision early and then have visual impairment for longer in your life, but have a better chance that you're going to recover some of that vision, or you can have your vision loss later in life, so you were sighted for longer, but your chance of recovery is less. Typically, optic neuropathy is the only associated factor from this mitochondrial DNA mutation, which is in all our cells. Figure that one out, right? And why does it come on suddenly like that? Why one eye in the end? Why? Who knows? Anyway, but there are pedigrees and individuals who have cardiac conduction defects, most often the hyperexcitability, the Wolff-Parkinson-White, those disorders. So they all need an EKG and rhythm strip. Some will have minor neurologic abnormalities. It's unclear whether it's related. And this whole issue of multiple sclerosis-like illness, I could give a whole lecture on it. It's probably coincidence with influence, but we'll deal with that another time. The patients you see will mostly have just optic neuropathy. The three primary mutations, which commercially is what usually gets tested for, are these positions in the mitochondrial DNA that code for proteins necessary for complex 1. And about 70 to 80% of cases will be the 11778 mutation, the most common mutation, the one with the worst prognosis for visual recovery. About 10 to 15% are these two. This one, 14484, very common in French Canada, has the highest rate of spontaneous recovery. What determines phenotype? Not everybody who carries this mutation has vision loss. Look at this pedigree. There are many who never have vision loss in their lifetime. So what decides that? So we know it has something to do with having a mutation. There might be other mitochondrial DNA factors. We think there might be a nuclear factor on the X chromosome explaining why it's men who express it, but we have not been able to localize it. And then definitely cigarettes and binge alcohol. So if you have a carrier, you really want to tell them you don't smoke anything that makes free radicals, because that damages mitochondrial function. So any kind of smoking, cigars, cigarettes, cannabis, whatever, any kind of smoking, and then high alcohol use, binge type drinking. Now, you mentioned OPA1, Kurs disease, dominant optic atrophy. So this is the one where the kid fails the school eye exam, right? So it's insidious onset, usually in the first decade of life. By age 11, easily 60 to 80% of patients, if you know the family and you're following, have it. On the other hand, the vision loss is usually not so bad. So what I get a lot of are the unexplained optic neuropathies in the 50-year-old who just failed their driver's license and really hadn't had an eye exam before. And they've gone through their whole life thinking that everything's just a little blurry. And so think about it with unexplained bilateral optic neuropathy. They usually lose about a line of vision every 10 years. Patrick B. Wyman's group says it's 3 lines of vision every 10 years. They will have some degree of progression, and it's typically symmetric. And these are the classic cecocentral scotomas. This is a girl and this wedge, 10-year-old girl. This is a wedge of optic atrophy. They sometimes get called glaucoma because it's excavated, but that pale rim should never be called glaucoma. One of the most important historical questions I ask when I have this 40, 50-year-old person comes in and they have bilateral unexplained optic neuropathy, I say, family history, no one has any vision loss. I was like, well, anyone in your family have glaucoma? Oh yeah, my father and his father, or his mother, had glaucoma. Well, what was their glaucoma like? Well, they didn't see very well centrally. Did they? No. Glaucoma, usually they see well centrally. They don't tend to go blind from it, and it's just a tip-off that somebody made the wrong diagnosis. You can have someone with 20/30 vision and a little pallor, and someone with 20/80 vision and lots of pallor in the same family. And so you have to think about the possibility. There are pedigrees of dominant optic atrophy with associated deafness, both congenital and later in life. There are rare pedigrees with cataracts, and there are rare pedigrees who will go on to develop chronic progressive external ophthalmoplegia and ragged red fibers on their muscle biopsies, suggesting this is a mitochondrial disease. Mitochondrial disease, but it's dominant optic atrophy. Well, wait. So these were the Danish pedigrees right across the water that Paul Kjær studied in Denmark to come up with this entity of dominant optic atrophy. And it's really cool because his daughter Bridget, who's still alive, who I met a few years ago, did ophthalmology and genetics. He was an ophthalmologist, she did ophthalmology and genetics, and she was part of the first group to take those pedigrees and find the locus of autosomal dominant optic atrophy to be on chromosome number 3. It's the OPA1 gene. That accounts for about 50 to 60% of all dominant optic atrophy cases. There are other loci that are being found, but what's interesting about the gene product of this OPA1 gene is that it's a protein that is absolutely essential for mitochondrial function. So it's a mitochondrial disease too, suggesting that there is something about the mitochondria something about the optic nerve that really gets perturbed when it's bothered, when its mitochondrial function is bothered. There's something very important about mitochondrial function in the optic nerve. And indeed, we talked about these 2 optic neuropathies. There are multiple other optic neuropathies associated with other neurologic and systemic abnormalities, and several of them, like Friedreich's ataxia and Charcot-Marie-Tooth type 4, actually we know the gene product, and it's a mitochondrial protein that's coded for in the nucleus. So these are basically all mitochondropathies, if you want to call them, with a final common pathway. So if you see someone you suspect a mitochondrial disorder, in addition to the usual and ruling out other causes of optic neuropathy, EKG can be life-threatening, life-saving. Audiogram, if you've got dominant optic atrophy, is very important because so many of these patients may have deafness. And now we can test. There are panels for optic atrophy testing for the nucleus, and then of course there are ways to screen the mitochondrial DNA. But I'd like to spend the last few minutes talking about some exciting new stuff. So this is not review, this is to tell you about stuff going on with treatment of mitochondrial diseases in general, but Leber's in particular. So first of all, make sure you know what you're talking about with genetic counseling. So if you've got a young guy sitting there, he's blind from labors, and his sister drove him in, you can tell, and he's got his fiancée, you can tell him absolutely, positively that his children cannot get that disease. Absolutely. But you also have to tell the sighted sister with her little boys at her knees that she and her children are at risk. So it's a very important thing that you understand the way that it gets inherited. Symptomatic. This should not be poo-pooed, because the reality is that right now this is about the best thing you can do for these patients. So get them to a low vision service. In the early days we thought that the Leber's patients did very well with quality of life, but more recently they don't. They're miserable, and the reason mostly is, despite all the great assistive technology that's out there, they can't drive. And that's huge these days. It wasn't so huge back in 1963. So what can you do? Get them low vision aids. You can also tell them and their carriers and their family avoid tobacco use and heavy alcohol use. And there are some medications that have mitochondrial toxicity, like ethambutol and some of the antiretrovirus drugs. So if there is a choice in the matter, you might be able to step in with that. So what about treatment? So let's look first at treatment for mitochondrial disorders in general. There's a huge list. Nothing has been shown to work. Okay? Top on that list are the coenzyme Q10 and idebenone, and we'll get to that in a minute, but nothing has worked. So Leber's is like the disease everybody wants to study. If you've got some drug companies here supporting you, I can promise you, if they do anything with glaucoma or whatever, they love Leber's. Why? Because it's an optic neuropathy that has a window of opportunity. What other disease can you think of that you are absolutely certain that the other eye is going to be affected? It's an amazing model. It's in a laboratory. So number one, you've got, in 50% of cases, you've got this potential to stop the second eye from happening. You'd need 10 patients in which you did that, and you prove efficacy of the drug. Secondly, the target of the problem is the retinal ganglion cell. It's not like in Parkinson's where it's deep in the brain and the midbrain, right? You can get at the retinal ganglion cells directly. You can give them a drop, or you can stick a needle in their eye and deliver the drug right there. And so this accessibility and this sudden onset, so you know exactly when to treat, make it a very important laboratory. And we tried that. We tried to stop second eye from happening by using brimonidine, which supposedly was going to be an anti-apoptotic factor, and we failed. All 9 eyes developed the second eye, even though we got them at 2025. But what's important here is, if you look, these are all the cases that we saw their good eye. This was the unaffected eye. Look, 7 of them already had, even though they had 20/20 vision, they already had a central depression, suggesting that even though it looks like it's sequential, it may be concurrent, and it's just subclinical when they show up with their first eye. So that's depressing. So the 2 that have been used in mitochondrial diseases the most are coenzyme Q10 and idebenone. Idebenone is sort of like son of coenzyme Q10, more powerful, and penetrates the blood-brain barrier more. And idebenone was tried in a placebo-controlled study and in a retrospective study in patients with Leber's, and there are mixed results. So Corelli's study from Italy showed that he just gave them to patients and then he retrospectively analyzed. He didn't randomize the patients. They had to be within 1 year of onset and have up to 5 years of follow-up. And he found that there was an increased frequency of improvement in the 11778 patients who took idebenone. It's not a great study, but it sets the stage. And the RODOS trial, which was a randomized controlled trial, but they let people in who had vision loss as long as 5 years. Those are dead nerves. I'm not sure anything could resurrect them. And indeed, they did not meet their primary endpoint. However, if you look only at the patients who had discordant vision, meaning one eye was worse than the other, meaning they were early in their course. There was a 4 to 5 line difference in outcome in favor of Idebenol. So it is EMA approved. Do you get it in Sweden? Can you get Idebenol? Yep, it is EMA approved. It's not FDA approved. But my patients get it over the internet, and they pay for it.
How much do they pay?
Pardon?
How much do they pay over the internet?
I think total for the year is about $2,000. It's not outrageous. You know,
Here is
for
$50,000.
50,000? You're kidding me.
No, no.
Yeah, no. I guess you're taking the risk. You're taking the risk online of maybe not getting what you're paying for. I don't know. Anyway, it's the best we can do. Iloviprotide is the new kid on the block that's being tested, mostly by Alfredo Seduce and Rustin. And then there's gene therapy, and I just want to spend a few minutes letting you know where we stand on that. So what are the challenges? They're typical for any gene therapy, right? That you have to make sure you get the right vector, you have to deliver it to the right place, it has to get into the mitochondria, it has to get into the mitochondrial subunit. I mean, there's a lot of stuff you have to get along with. And on top of that, we know how to get genes inserted into the nucleus. We do not know how to get genes directly into mitochondrial DNA. So we have to figure out a way around that, and we'll tell you that in a minute. So what are some of the gene therapies? There are basically two that I'd like to talk to you about. One is basically cures the disease. Not in an individual, but in a germline. So it's called nuclear transfer techniques. It's been proven in primates. It's safe. You can easily do it. You basically take a mother's egg who has abnormal mutant mitochondrial DNA. You extract her nucleus, and you put it in a donor cytoplasm whose nucleus has been extracted. You put it together, you do in vitro fertilization with the partner, put it back in her, and you end up with a baby who has the nuclear makeup of mom and dad and the mitochondrial DNA makeup of the donor. Phenomenal. Star Wars, right? Primates not ready for prime time? You bet it sure is ready for prime time. Look at this. This boy is now 3 years old. Birth a baby with 3 parents. A U.S. doctor went to Mexico to help a Jordanian couple conceive a baby with 3 genetic parents. Now, this mother had the point mutation at 8993, the NARC mutation, which is, if it's not lethal, it's just terribly destructive. And so, but you could do this with labors. And you could keep it from happening in that next generation. Something to think about. But what about the individuals now? So all the gene therapy that's being done is being done with called allotopic rescue. And allotopic rescue takes advantage of what you just learned. It basically inserts the gene into the nuclear DNA, where it is then transcribed in the endoplasmic reticulum with the little tag on it that tells that protein it should go into the mitochondria. Cool, huh? So all the studies have been done with the 11778 mutation because it's the most severe and the most common. And it was proven in the US in John Guy's group in Florida and in the French group in Paris to work on rodent models, 1 mice, 1 rat. It then was shown to be safe in the 2 groups on either side of the ocean in humans. And subsequently, in China, it's being used. I think they've treated like 180 patients with labors already with this gene therapy. And the phase 3 trials in Europe and the US are rescue, which is treating patients within 6 months of onset of immune loss, and reverse, which is treating patients 6 months to 1 year. And I'll show you some of the results, which have not been the slam dunk we were hoping for, but some very interesting findings. So reverse, first of all, it's well tolerated. Sticking this material in the vitreous with an injection does cause intraocular inflammation and elevated intraocular pressure, but it is treatable, and there were no withdrawals on that basis, so that was fine. And here's the 96-week data. And what has been absolutely surprising is that these patients did improve by the endpoint, 15 letters more. But so did the untreated eye. So, that's weird, right? Let's talk about it. And if you take all the treated eyes and use only a 2-line or a 10-letter basis, which is what's used for the idebenone studies these days, you find that 68% of them reach that response. And if you look at who's better than 2200, there's a 4 times greater chance that the injected eye was better than 2200. And the same goes for contrast sensitivity. Both got better, but more in the treated eye. And all the patients felt that their quality of life was enhanced. That could be easily placebo, right? Rescue, the within 6 months. Same thing. First you have to account for it going down as part of the natural history, but then both got better more than we would have expected. Okay. And the same with contrast sensitivity. So here's reverse and rescue, and you can almost put them on top of each other because this would happen right about there at 6 months. And then we have reflect, in which we're injecting both eyes. The first eye gets both. The first eye, everybody gets the drug. The second eye, half placebo injected, half drug injected. And the outcome is the other eye. And it's ongoing right now, everywhere. We've finished enrollment and we're going to see. But I'd like to leave you with some really interesting questions. What is this? Is there really a bilateral effect? And I can tell you, I'm one of these people who thinks this is just, we only have 40 patients in each group. I'm sure it's just noise or placebo effect. Or maybe we didn't get the labor's natural history right. But I am beginning to be a believer. And there are some studies going on which will see whether it's true. But when you inject something in one eye, there is a possibility that it will go down the optic nerve, into the chiasm, and up to the other optic nerve and eye. And there are studies to see if that's possible with primates right now. But when you think about, this has been known for anti-VEGF for a long time, that you can actually find it in the other eye. So we'll see. So maybe it isn't as bad a result as I thought, but it isn't the slam dunk that I wanted. And so I think we need 2 outcome measures. I think time may be vision. I think we need to get in there faster than 6 months or even a few months. I think it may be like a stroke. I think if we really want to do something, we have to get in there within days. But what I will leave you with is what I think the best thing that these trials have done for this disease and for labors. And it all has to do with social media. When I did the study with bermonidine in early 2000s, it took 2 years to get 9 patients. We had 90 some odd patients within 18 months. So 76 patients in 18 months, and then another 90 patients in less than a year recruited with labors. And the reason is this, and this woman named Lisa Plessner, who was a mother of a labors patient. She set up this website, and I'm sure there's a European website, and I'm sure you have your own Sweden website, but this is global too. So I'm sure they are in contact with her. Basically, she has linked all these people. It's excellent for their education, for their support groups, for everything like that. But for me, very selfishly, it's allowed her, we tell her, okay, we need patients with the 11778 mutation between this age who've had it for this long, and she clicks, because HIPAA laws would keep me from being able to call somebody or do something. But she doesn't have HIPAA laws. So she just hits her click on her mouse, and she got all these patients for us. So if you have rare disease people, this is a model. This is a model for any clinical trial that you're going to do. All right, that was it for all of our optic neuropathies, and tomorrow we have some cases. Thanks.